And finally, we get to category 2 blocking, which I showed a picture of earlier. This patient is face up. This patient has either a right UMS, or they might have a left LLL, or they might have both. Notice that the high block goes straight in, and it's bisected by the crest of the ilium. The low block is placed through the acetabular area, which you'll find by finding the greater trochanter. You will leave the blocks in place until the weak arm fossa becomes strong. So this blocking usually only takes 30 seconds, and I think it's what it doesn't do that makes all the difference. An awful lot of people need repeated PI or AS adjustments if done, especially prone drop, but also side posture. And it's because they're unstable. When you cavitate the joint, you might not be helping instability. I think you're producing an enormous amount of very good neurological input from the joint. You're enabling the joint to reset neurologically. But if it's too unstable, it won't hold. In this position, or if you're doing supine drop table, you're not cavitating the joint on purpose, and you're not putting too much stress in the interosseous or other weight-bearing ligaments. So I think sometimes the results you get are from what you don't do versus what you do. What I have here is a picture of category 2 blocking. This patient has upper inguinal ligament pain worse on the right and medial knee pain worse on the right. After palpating both sides and asking, is either side worse? And that right side is the short leg side. So we now have permission from the patient to place the high block on the right. Or they have lower inguinal ligament pain, palpatory pain, and lateral leg pain worse on the left, and that's the long leg side. We now have permission from the patient to place the low block. The low block is placed through the greater trochanter on the long leg side, facing up at about a 45, aiming at the high block. Now, in the left picture, there's a line going down that block, and there's an arrow saying top of iliac crest. We place the block underneath the patient so that the iliac crest comes no higher than the middle of the block. And the low block is placed through the greater trochanter, facing up at that high block. The patient then straightens the legs, and we redo the arm fossa test immediately. We wouldn't be using blocks unless the patient had a weak arm fossa. When the arm fossa becomes strong, wherever it was weak, we remove the blocks. That's all the patient needs. The average amount of time that it takes for a typical patient to become strong is 30 seconds. The maximum time is 2 minutes. Don't leave a patient on the block for more than 2 minutes. Just take them out. If they don't get strong, you've probably made a mistake. Take them out. This is an SOT paper that was done during the spring seminar back in 1988 in Hawaii. And it's just a paper that discusses how ligaments heal. And they heal by a process called collagen gelation. And it's how a lot of soft tissue heals. Collagen is laid down, and the actual mechanical property of the collagen is at first very liquid, and then it becomes like jelly or jello and becomes firmer and firmer. And they're saying that blocking causes this to happen. I sort of disagree. I think blocking doesn't prevent it from happening. But I think sometimes if you get adjusted too soon or too hard, you may be preventing soft tissue healing. I'll let you read this. And these are just pictures of the sartorius muscle, which is a major player in upper weak fossa and also in the U from UMS. And the M from medial knee. You can see that the sartorius originates in the upper area and inserts medial knee. And then there's a picture of the rectus abdominis, which inserts into the upper part of the pubic bone. So that's your L, your first L in LLL, lower inguinal ligament, maybe lower weak fossa. And you've got that rectus pulling up, and you've got the sartorius pulling down. There should be a dynamic balance there where there's not too much or too little of either one, resulting in a PI or an AS ilium. The trochanter belt is an orthopedic device that the patient can wear if they have really separated that SI joint. It's worn just beneath the ASISs, just above the greater trochanters. It's also called a sacroiliac belt. It's worn not too tight, snug, and it's worn underneath the clothes most of the time. The general way we wear this is for 2 weeks in a row. The first week being 5 days, anywhere between 5 and 7 days. The first week you want to wear that thing 24 hours a day. Take it off for showering, for bathroom. Put it back on, but wear it when you're sleeping for the first week or so. Then for the second week, just when you're on your feet. Or sitting in a chair, so you don't have to wear it to bed. And very helpful. I used lots of them when I was in practice. I'll let you read about it. It's self-explanatory, and I'll let you read this for yourself. It's a study about SI joint instability and the SI joint belts. And this is a study that was done about the iliolumbar ligament. I wasn't aware that the iliolumbar ligament is one part of the interosseous sacroiliac ligament. It's the part that comes out of the SI joint and goes up to L5. So it seems that L5 is a major player in stability of the SI joint and vice versa. A lot of medical papers show that it's difficult to distinguish between SI joint and lumbar as a cause of pain in low back patients. I think chiropractors have an easier time with that than medical doctors do, but medical doctors don't look for subluxation, and we do. So make sure you read this. The belt, I'm not going to spend a lot of on-time patience. I know time with this you guys can read, so make sure you do read these clinical studies. And this is a little exam that I would give in class. I would point to the different numbers and ask, what they mean. What are the parts of this? So what I'd like you all to do is take a look at this slide and see if you can identify the structure that the numbers are looking at, but especially the sphenobasilar synchondrosis. A synchondrosis is a joint that is started in disc, I'm almost done, and becomes very stiff with age. So the joint between the occiput, which is pictured here in green, and the sphenoid, which is in gray, is called the sphenobasilar joint. It's where the sphenoid meets the basilar part of the occiput, which contains the foramen magnum. And that's a major joint in SOT, because we're going to look at a picture here of here the patient's facing to the right. So you're looking at them from the side, and you're looking at their right side. In the front is the sphenoid bone with the pterygoid process hanging down, and then there's a joint between occiput and the sphenoid. That is the sphenobasilar joint. On inhalation, that joint moves slightly superior. That's called sphenobasilar flexion. And these are just terms that describe the motion of a joint. And on exhalation, that joint moves into exhalation, it moves down. So inhale and exhale can affect the positioning of this joint to a very, very minor degree. That joint can also laterally flex, and it can twist. And that becomes important when you get into SOT craniopathy. Don't worry about this slide, and don't worry about that slide, and don't worry about this slide. Okay, and don't worry too much about these slides. These are, I think, over-exaggerations of what's happening. So I don't find them of very much value, and I don't expect you to. This is a schematic of the sacrum at the bottom and the occiput and the upper cervicals at the top, showing a relationship between the top and the bottom through the dura mater. And this is a theoretical issue in all of SOT. It helps explain the cord distortion dentate ligament hypothesis in upper cervical, and you don't have to know much about it. And finally, I'm showing a procedure called basic 2 cranial. And when I get to this, well, I'm talking about it right now. What do? We put one hand on the forehead and one hand on the back of the head, and we have the patient do a few things to help us flex that sphenobasilar joint, because we find that on most category 2 patients, that joint is stuck in extension. So they have to do a deep inhale, and we have them do a few other things to make this happen. My force with my backhand is S to I and A to P, and with the heel of my front hand is S to I and A to P. The backhand is S to I, P to A. My mistake. Front hand is S to I, A to P. So we're compressing the head from front to back, and we're pushing the occiput and the frontal bone S to I. This helps flex that sphenobasilar joint, which is usually stuck in extension. This is called basic 2 cranial, and it can be done automatically on all Cat 2 patients. And it can also be done on category 2 patients who you would suspect should have a weak arm fossa or should have a strong arm fossa when you block them, but they don't. So while they're lying on the blocks, you have to hold on. God.
I gotta go. Doug's gotta be the vet at 4:15. It's after 4.
Okay, I'm gonna finish recording this. I'm sorry for the interruption. This is basic 2. It's used during a category 2 visit. It's probably fine to do this automatically when you block a patient. And then after you finish this basic 2 procedure, go down. The arm fossa should be strong. Remove the blocks. You can also do it when you block a patient correctly and the arm fossa doesn't strengthen within the allotted 2 minutes. You're putting a force into the skull. The patient is helping with a deep inhalation, sucking on the thumb or the tongue, and dorsiflexing both feet. And you hold for about 10 seconds, repeat maybe 2 or 3 more times. That's called basic 2. It flexes and then relaxes the sphenobasilar joint. You can also pull I to S on exhalation. That's an option. DeJarnette developed cervical stair-stepping, which is a form of motion palpation of the cervical spine. It balances the cervical muscles. It's performed mid-sagittally, You can also take the head at each of the 4 stair steps and move it into straight lateral translation. I find that it's very helpful to find the level of fixation that you might not find when you do mid-sagittal stair stepping. So you're looking for a restriction going from step 1 all the way to step 4. Now step 1 is when you push S to I on the top of the head and the head comes off the table. And then there'll be a little resistance before you go to step 2. Step 1 is T1 and C7. Step 2 is C6 and 5. Step 4 is C3 and 4. And step 4 is C1 and 2. So if you get that midline restriction, or if you feel a restriction at any of the steps, when you take the head into lateral translation, you can then do a figure 8 maneuver, and there is a video showing the cervical stair stepping. It's a pretty neat procedure. Years ago I had an elderly patient who had neck pain for years and she was going on a cruise. She was in her mid 80s, I think, and she was wondering, could I do anything about her neck pain so that she could go on her cruise and be more comfortable. She had never been to a chiropractor before. She was in her mid 80s. She had a lot of osteoporosis. She had very thin disc spaces in her neck, a lot of arthritis. So I treated her by doing stair stepping and figure 8 pretty much at every cervical level. And I also stripped out the SCM muscles and the scalenes and did some trigger point work in the traps. And she was so happy at the end of 2 weeks. She came to see me 3 times a week for 2 weeks, and then she went on her cruise pretty much pain-free. We were both somewhat surprised. So here's a photograph of the head coming off the table into probably all the way up to step 4. And also a photograph of the doctor taking the head all the way to the right and all the way to the left into lateral translation. I find that it's a lot easier to feel the restriction at the different levels when you take the head all the way right and all the way left. Let's say that at a specific level, you can't take the head as far to the right as you can to the left. That translates to a body left. So if you can't take the head to the right, consider that the muscles on the left are preventing the head from translating to the right, and it's at a specific level. If you find that the neck is completely locked, you just can't hardly get the head off the table at all, you're probably dealing with a Category 1 patient who needs their sacrum adjusted. The most common listings I find in the sacrum in cases like this are base posterior, apex posterior, or sacral apex left or right, or sacral base left or right, where the entire sacrum is involved, and therefore the muscle compensation in the neck is also bilateral. So I'll go down and adjust the sacrum, and I'll usually feel the neck free up almost immediately. It's a very miraculous palpation. It's a neat experience for the patient too. And usually I'll remind them that indeed they have more neck motion after I adjusted their low back, so they can become aware of it. A lot of times patients are oblivious to the changes that you feel that you think would be obvious to anybody, so you have to bring their attention to it. Okay?